Hello and welcome back to Science of Medicine. I want to talk about the scientific process and how that impacts clinical study designs in this presentation. Before I do that, I want to be clear about science and the way in which we construct arguments for understanding how our universe works. I'm not trying to be disparaging to religious traditions in any fashion whatsoever, but I do want to point out something that does tend to crop up from time to time. So when I talk about science, this is the way that humans try to understand how our universe works. We construct it. I don't think dolphins make science. One of the central tenets of science is that anything that I hypothesize, any explanations or theories that actually describe how the universe works must be falsifiable. What that means is that somebody can design and execute a series of experiments that can disprove my hypothesis or my theory, but I can never prove it. It always has to be open to that falsifiability. I can test the predictions. I also value evidence from experiments. Now, there are different types of evidence. There are direct measures that are more reliable than indirect measures. Studies that are done on larger numbers of people are more reliable than done on smaller numbers. And so understanding that process clinically for science is important to doing the science and interpreting it. Now, religion seeks to understand why our universe is the way that it is. It's normally revealed to humans. It is, as a central tenet, comprised of non-falsifiable beliefs. I have faith that these things are true. No evidence is necessary, and any evidence that's offered doesn't really change my faith if I truly have it. Now, sometimes people use a pseudo-religious type argument that's framed in terms of science. This is an inappropriate way of knowing how our universe works. The way you can tell about this is that as you listen to the person or read what they're writing, they're really applying their tenets of religion, in particular non-falsifiable beliefs, to how questions. In essence, they're trying to answer the wrong question. They do not accept evidence. There is nothing that you can provide to those people that would make them change their mind. They simply believe what they believe. That is not what I'm going to discuss. I'm going to actually stay within the realm of science as it applies to medicine. So what is that process? So you may recall from many classes that you've had in science that we first start with a question, and we have to really formulate that question well. Otherwise, everything that we design in terms of experiments, all the data that we collect from that, will be answering the wrong question. So we formulate this question, and then based upon our current understanding of science, we would make a hypothesis. We would design an experiment or a series of experiments to test that hypothesis, and then perform those experiments, observing and recording events. We then replicate the experiments and evaluate those results and the hypothesis in light of that. And one of the other very important things that we do is that we put this out there for the scrutiny of other people. So look at the data, look at the experiments. Were they designed well? Were these things that did answer the question? And maybe my interpretation is off base. It's a process that involves a lot of people from different backgrounds with different perspectives that analyze that. So let's give some examples. Let's start with a medical question such as, does good control of glucose in patients with diabetes mellitus reduce the incidence of coronary artery disease? Now, a little bit of background. Some people have a disease called diabetes mellitus in which they are not able to adequately regulate blood glucose levels. So for example, if they eat a sandwich, their blood glucose levels would go up. Now this comes in different types. There are types dealing with insulin resistance, those are type 2, and type 1 dealing with a lack of insulin. So with people that have long-standing diabetes mellitus, we find that that increased level of glucose in the blood has a detrimental effect on many proteins and structures, including those in the blood vessels, and that can lead to heart attacks, coronary artery disease. So that's the basis for this question. In any kind of clinical study, I'm going to look at my question and I'm going to try to answer it by designing an appropriate experiment. But I'm going to have some things in common. The first thing is, what's the study population? That is, whom am I studying with regard to this particular question? In this particular case, it could be people with type 1 or type 2 diabetes. It could be people that just were diagnosed with it or have had it for 10 years or more. And then there are other things that are what are called confounders that might skew the results of my coronary artery disease. For example, we know that smoking, family history of coronary artery disease, predicts for increased incidence of coronary artery disease. The second thing that we want to look at is the intervention. How are we going to define whatever it is that we're going to do with regard to good glucose control? Do we want to give them a medicine? Do we want to give them several medicines? Do we want to look at diet? How do we want to do that intervention? And then what are we going to look for as our primary endpoint? Do we want to look at a person who dies of a heart attack, just has symptoms of a heart attack, has a heart attack? And then lastly, what kind of study is going to be an appropriate study to answer this question? So let's step through those. Based on this question, I'm going to hypothesize that in patients with long-standing type 2 diabetes mellitus, and I would define long-standing in my experimental section. It could be people that are 10 years or more with type 2 diabetes, or 5 years or 15 years. Intensive therapy, which again I would have to define, could be in terms of a drug, a combination of medications, to maintain a hemoglobin A1C level of less than 6.5. Now, glycosylated hemoglobin is one measure of average glucose in the blood. And that level of 6.5 denotes a certain level that is average. And it will decrease the incidence of heart attack. So, hypothesis, in patients with long-standing type 2 diabetes mellitus, intensive therapy to maintain hemoglobin A1C level less than 6.5 will decrease the incidence of a heart attack. So, my study population, people with long-standing type 2 diabetes mellitus. What's my intervention? Intensive therapy, which I'm going to have to define in the experimental protocol, and I'm going to include in that definition the ability to maintain a hemoglobin A1C level less than 6.5. And what's my primary endpoint? I'm going to choose a heart attack. Now, because my hypothesis has to be falsifiable, I cannot demonstrate that this hypothesis is true. So what I do is I formulate a null hypothesis. And then I can demonstrate that that is false. And I can further talk about the certainty of that being false in terms of statistics, which we'll talk about in the later section. And if that null hypothesis is then false, my hypothesis is supported. Doesn't mean that it's true, it just means that I'm supporting it. So let's look at a null hypothesis. In patients with long-standing type 2 diabetes mellitus, intensive therapy to maintain the hemoglobin A1C level less than 6.5 will be associated with no difference in heart attack, in the incidence of heart attack. So I have two populations, one that have a hemoglobin A1C level of 6.5 or greater, and those that are less than 6.5. These are all of the long-standing type 2 diabetics that I've actually included in my study, and I look at the level of heart attack, how many have them in each of those groups, and I can do my experiment. I have a falsifiable null hypothesis. I can measure this. It's testable. and it is addressing the question. So it's a good null hypothesis. Let's do some examples. Suppose I have a question of, do women age 75 and older with vitamin D deficiency, which I can define, have more femoral neck fractures than those without vitamin D? So the long bone towards your hip is called the femur, and at the very top of where it articulates with the hip is a very common site for a fracture. This is common in people that have osteoporosis, and osteoporosis can be associated with people who have a low vitamin D level. So in this particular case, what is my study population? That's right, it's women age 75 and older. Now the way I would frame this is that I have women age 75 and older. Some of them have vitamin D deficiency, some of them don't. But my study population, the people I'm going to examine, are going to be women age 75 and older. What's my primary endpoint? What am I going to look for? That's right, I'm going to look for femoral neck fractures. What about a null hypothesis for this? Which of these do you think is a good null hypothesis? So I think the second one is a reasonable null hypothesis. Women age 75 and older with vitamin D deficiency will have the same number of femoral neck fractures as those without vitamin D deficiency. This addresses the question. It is testable and falsifiable. How do we go about answering clinical questions? We have 4 different types of studies that I'm going to discuss. 2 of them go back in time. What that means is that I have a time right now, and if I'm looking at something that has already occurred, we call that a retrospective study. So the first type of retrospective study is called a case control study. And so I'm going to have to go back in time, which means that I'm going to have to examine records or examine something that has already been done, or look for people's recollection, although that's not quite as good. And what I'm going to do is let's say I examine the medical records of people with a disease. And I'm going to pick a control group that don't have the disease. And I'm going to look back in time at those individuals and maybe look and see if they were exposed to various things that I'm investigating. So let's say, for example, before the early 1960s, I want to look at lung cancer. And I want to look at people that were smoking cigarettes. And I compare it with people that were not smoking cigarettes. And I look backwards in time and I go, was smoking associated with more lung cancer than not smoking? Now, it is advantageous to do these things in a case control, especially if I have a very rare disorder. My lung cancer example is not a very rare disorder, unfortunately. But let's say that a disease only occurs in 1 in a million people. Well, if you wanted to do a prospective study, a study that starts now and goes forward in time, that's tough if you have 1 in a million as the incidence of your disease. Because now, if you collected 100,000 people for your study, there's only a 1 in 10 chance that there'll be even one person that will develop that disease. On the other hand, if I know the people that already have the disease and I look backwards in time, it really is about the only feasible way that I can do it for very rare disorders, or for those that require a very long time from whatever the factor is to development of the disease. Now, I don't need as many subjects in doing this, and it's pretty inexpensive. It requires that you do some computer work with the electronic health records. Disadvantages are that, first off, you don't necessarily know if that cause and effect temporal relationship is there. I can get biased by selecting certain cases. I have to especially take very, very good care in my controls, because a lot of times I can have confounders, things that can also be linked to the disease that I'm looking at, but that I may not control for. For example, in my smoking case, if I look back at lung cancer, perhaps there would be something else that would also be associated or be causative of lung cancer, in which case that would be a confounder. For example, if I looked at people who smoked and also had exposure to asbestos. So a case control study is a study that looks backwards in time. And one of the prospective studies is called a cohort study. This is an observational prospective study, which means I'm starting it now and then I'm looking forward in time. And I have some factor present and some factor that might be absent. I look at those people with the factor, how many develop disease, how many don't develop disease. And I looked at those with the factor under consideration absent, how many of those develop disease versus how many don't. And then I can make a comparison and see whether that factor is associated with an increased incidence of that particular disease. Now, this is prospective. It's going forward in time. It's observational. I'm not making this factor be present. I'm simply observing whether it is or not. There are many studies that are done as a cohort design. You can get enormous amounts of data from this, and you can establish timing if you actually do several, normally these are done with surveys, but if you do several polling of the individuals involved in this cohort study. And you can try to match them for those confounders. You can't definitely know if there's a hidden confounder, but you can try to match them as much as you can. Now, it has some disadvantages. First off, you can lose people to follow-up. Somebody may have started your study and then they dropped out, they died, something happened, and that can lead to loss of follow-up. For small or short time frame cohort studies, you can also have a change in habit over time if people know you're observing them. For example, if I said, I'm going to study how diet and use of a Mediterranean diet impacts a person's ability to perform well on an examination in college. And I'm going to take my class and I'm going to see who's following this good diet and who's not. Well, it may be that people over a short period of time alter their diet, because if I'm asking them questions about how many cheese puffs they've had or how many Twinkies or things like that, they may not want to really disclose that to me. And so they may try to make their diet better during that time. So some people will change their habits. Now, if you do studies over 10 years or 20 years or something, I would say that's probably a lifelong change if they're changing. We still have the possibility of having hidden confounders, things that we don't know about that would somehow skew this. There is still a selection bias associated with this. And of course, you have to actually go out and collect this data for large numbers of people, and that can be expensive. Now, another type of prospective trial is a clinical trial. And this prospective experimental study is considered to be the gold standard for our medical trials. In this case, I'm going to have a group of people. Most of the clinical trials are done with populations that have a disease, and I'm looking at taking some intervention that might help with the management or help mitigate some complication of the disease. But sometimes I'll do it with people without the disease if I'm studying something else. But most of the time it's done with people with disease. And in this experimental design, I'm going to either do something or I'm not going to do something. Or I might compare two things that I'm doing. For example, I might have a standard treatment and then a new treatment. And I will look in both of these arms, if you will, of the clinical trial, those that had the intervention and those that didn't, and I'm going to look at some outcome, some primary outcome. And I'm going to compare the differences between those two arms. Now, this is our gold standard for clinical trials because it's the only experimental design. I do have the possibility of making the intervention blinded. And what I mean by blinded is I don't know, or the participant doesn't know whether or not they're getting the study drug or intervention or not, or just the placebo. So in the case where the participant does not know, I call that a single-blinded clinical trial. And if it's I don't know, nor does the patient know, it's a double-blinded study. Now, there are several advantages to this clinical trial. First off, it's the only experimental design study that I have. And if I randomize people, then I should have an unbiased distribution of confounders as long as I have enough people to make the randomization significant. So if I had 1,000 people, 500 in the interventional group, 500 in the non-intervention group, then I would go ahead and be equally likely to have confounder A, B, and C in both those groups. If I bias, if I want to eliminate bias in the trials, I can blind, both single or double blind. And that facilitates my interpretation of these results. As you can imagine, such trials cost a lot of money, which is a disadvantage. I still have the problem with loss to follow-up, and I also have the possibility of selection bias. For example, many of our studies done 30, 40 years ago were done predominantly on white males. And so their ability to extrapolate to other genders or races are compromised by that. And it's one thing we found out in terms of coronary artery disease is that men and women are very different in terms of the way in which they look or clinically present for coronary artery disease. So to remind you in terms of the clinical trial, most of them are randomized. I do have the possibility of not randomizing them. If I randomize them, I can either blind them, either the participants or the participants and the people who are running the clinical trial or not. Now the last study that I have to clinically assess some question is the meta-analysis. And this is the second type of retrospective, the first being the case control. So this is a review that combines multiple studies. So several different authors have studied a problem and they've reported their results. Now somebody is going to come and look at those studies and combine them in a way such that I have more patients that have this particular event. So I could look at several clinical trials, for example, and see does this medication that I'm using as my intervention really and truly help with this primary outcome or not. So it has greater statistical power and the ability to generalize than just one single study. It also allows me to analyze subgroups that may have just had too few of events to be statistically meaningful, but when you start stacking on several trials, you might get to the several thousands of patients and be able to actually extract more information from it. Of course, it's very time consuming to identify and to do these studies, and not all the studies will be able to have adequate data for use in this kind of meta-analysis. Now, here is an example of a report from a meta-analysis. And it's normally presented as what's called a forest plot. Now, in a forest plot, I show all of the different studies that are involved, and I can individually plot them with their error bars. And then afterwards, I can do my study. So right here, overall is not the name of an author, it's the overall result of combining these studies, and that's shown right here. And we'll talk more about forest plots in another YouTube video. So let's give some examples. So here's a study in the New England Journal of Medicine that was undertaken to investigate whether a diabetic drug reduced kidney disease in diabetic patients compared to a placebo. 9,340 adults were randomly assigned to receive either the study drug or the placebo, and the study personnel were unaware of who received each. For one measure of kidney function, new onset macroalbuminuria, 161 patients in the drug group versus 215 patients in the placebo group developed that macroalbuminuria. So one of the things, just as a note, your kidneys will filter your blood. Normally, albumin is not passed through the kidneys and then urinated out. However, you can damage the filtration apparatus called the glomerulus, the kidneys, with diabetes, and that can lead to this macroalbuminuria. In another measure of kidney disease, the number of patients whose kidneys failed and required dialysis, that is, complete filtering of the blood done without the use of your kidneys, 56 patients in the study drug group and 64 patients in the placebo group saw complete kidney failure that required dialysis. So given this information, what's my study population? That's right, these are the adult diabetic patients that I had in the study. What are the primary outcomes? So there were two, and you could argue one is the primary and the other is secondary, but what I'm looking for, what I measured in outcome, was first off, macroalbuminuria, and second, kidney failure that required dialysis. So those are the things that I actually measured. What kind of study did I use to do this? That's right, I used a randomized double-blinded clinical trial. I randomized them, and it's said in there, and then if the study personnel don't know, then neither do the participants in the study, so it's a double blind. Let's look at another study. So here's one that was in Journal of Clinical Oncology that examined the relationship between two supplemental B vitamins, B12 and B6, and lung cancer. 77,118 men and women aged 50 to 76 were recruited. Incident primary invasive lung cancers were ascertained by linking the participants to a population-based cancer registry. The 10-year average daily dose from individual and multivitamin supplements were ascertained by survey. Use of supplemental B6, folate, and B12 were not associated with lung cancer risk among women, whereas for B6 and B12 from individual supplemental sources, not from multivitamins, were associated with a 30 to 40% increase in lung cancer risk among men. The 10-year average for supplemental dose was also evaluated, and there was almost a twofold increase in lung cancer risk amongst men in the highest categories of vitamin B6 and B12 compared to those who didn't have those supplements. And for vitamin B6 and 12, the risk was even higher amongst men who were smoking at baseline. In addition, B6 and B12 associations were apparent in different types of this lung cancer, such as, but not adenocarcinoma. So, what type of study is being described here? That's right, this is a cohort study. I'm recruiting people. I'm not choosing whether or not I'm giving them B6 or B12. I'm simply polling them to see whether they are. And so I ascertain this by survey, and then I'm looking for things afterwards. What was my primary outcome? What was I measuring? That's right. I was looking for incident primary lung cancers. So I hope that this actually has helped you understand something about how science is done in terms of the different trials that we actually have, different ways of studying. I'm going to talk in our next session about disease and tests, and then come back to more statistical methods of analysis of these types of trials. So stay tuned.